Is there anything we can do from the get-go to reduce the chance of people getting shedding? Evolution to androgenetic hair loss, whereby one part of the scalp is thinning much more than another, but you're not making your hair worse by shampooing every day. The hair that's going to come out is the hair that's going to come out. What recommendations do we have to patients going through a shed? I think the first thing I say to patients is absolutely my very first thought is, I wonder if this patient is developing some androgenetic hair loss.
Welcome to Derm-It Trotter, Don't Swear About Skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter, Don't Swear About Skincare podcast. Today's episode, I've got Dr. Jeffrey Donovan, who's a dermatologist that specializes in, guess what? Hair loss. That's all he does. And for you listeners out there, you need to realize, dermatologists, we manage hair loss. Now, Jeff practices in British Columbia, Canada, and he's currently the president of the Canadian Hair Loss Foundation. So definitely a derm guru in the field of hair loss. So welcome to the podcast, Jeff. It's great to have you here.
Dr. Trotter, thanks so much. It's really wonderful to be covering this topic, and I'm looking forward to it.
Well, I followed you, and everything you do obviously is centered around hair loss, and a hot topic for our patients nowadays, and I think even for dermatologists in dealing with this, is hair loss surrounding GLP-1s and just how prevalent they've become. And people are really scared maybe to even go on them, knowing that weight loss might be a benefit that can motivate us to do a lot of scary things. But I think when people see hair loss as a side effect, it does make them pause. So I was going to have you kind of just take us back to kind of GLP-1s, how they've kind of entered, into our realm in dermatology, and talk about why do we even see hair loss with GLP-1s?
Isn't it incredible? I mean, these medications have really taken over the dialogue in terms of the common words that we're familiar with now that we weren't 5 years ago. But, I think an important theme today is we don't understand all of the facts. We certainly understand a lot, but we don't understand everything. We know that maybe 10 or 15% of people that use these medications are going to get hair loss, but not everybody does. And so I think that's really important to be aware of, that there's a good proportion of people that can use these medications successfully to, lose weight or manage diabetes and not experience hair loss. So it's not everyone, but it probably is around 15% of people that are going to get this. But we don't understand it all. Is it because the weight loss itself is causing the hair loss? That's the current theory, that if you lose weight faster, you're going to get more hair loss. If you have more dramatic weight loss, you're going to have more dramatic hair loss odds. But we don't understand it all yet.
You probably reassured some people out there, because I think just because it's so buzzy, people are hearing about it. They're probably thinking, oh, like 80% of people, 90% get hair loss. And if you're saying, probably around 15% get hair loss, then I told people, well, look at the flip side, right? 85% of people probably will not get hair loss. And I think that's really interesting, from the standpoint of the why, because if, you would think if it was related to the weight loss itself and how rapid that can happen with a lot of patients on GLP-1s, although we're titrating them to maybe help it be a little slower for people. But it is kind of interesting then mechanistically the why. So I think more will probably come on that research and how it's really affecting the hair follicle, or maybe people are genetically susceptible or other things going on. What about, some of the other side effects, I guess, that you might associate with GLP-1s? Like if somebody has nutritional issues or deficiencies linked to it, do you think those types of things play a role too into the hair loss? Or when you've evaluated people with GLP-1 related hair loss, are those not that common?
I think they're probably really relevant. And when I see patients with hair loss from GLP-1s, I really want to make sure that iron is okay, B12 is okay, vitamin D is okay, zinc is okay. These are the four main ones. And, if there are any deficiencies, then certainly we'll want to supplement. I think a key question for the future is there anything we can do from the get-go to reduce the chance of people getting shedding? Can we supplement generously with some of these things? Does that make any difference? Does the speed of hair loss make any difference? Does supplementing with collagen or excess protein, is this the way to go? And, I think on the internet, it seems much more clear. Of course, you should be doing that. Don't you know this? You should be taking 100 grams of protein, and you should be doing this. The reality is, we don't know.
Mm-hmm.
But those are the four main things that I check for. And sometimes they're low, and sometimes they're not. But I think that if you're going into starting a GLP-1 and you already have some kind of micronutrient deficiencies, it's possible you're setting yourself up for some greater odds of hair loss.
That makes sense. And I think the prevention part would probably make people feel better about it. I had a patient come in and she actually goes to a weight loss clinic ran by a plastic surgery group. And she told me right off the bat, they were recommending nutritional supplementation. Although she said there's no evidence, they really told me it might help, but they said, I could experience hair loss. So they just thought, let's try this. And I said, well, that's part of the key. We really don't know if they haven't checked values on you. And just like you mentioned, same labs that I checked on her, and they were all fine. So, I told her, I really don't know that this is going to change the likelihood of you having it, but still the odds are in your favor that you may not experience it. What about the different GLP-1s, though? I think that's a question a lot of people are wondering, if I'm going to be put on semaglutide or tirzepatide. Do we have any evidence in doing some of these reviews? Does the actual medication make a difference in the likelihood of you having hair loss? Or are they kind of all approached similarly, or we just don't know yet?
We really don't know yet. We have the most data for semaglutide and tirzepatide. And so because we have the most data on it, those are the two that rise to the top. But, we just don't have as much data for some of the others. And the thing that's so important about these GLPs is they're so different. And from what I hear, there's going to be even more GLPs coming out. There's going to be so many on the market in the next 10 years that we won't even know what the names are. And so I think that's really important because they probably do act slightly differently.
Mm-hmm.
And the thing that we're learning now is that, maybe just maybe some of these GLPs cause not only an increased risk of shedding, but maybe just maybe they push along the chance to develop genetic hair loss or androgenetic thinning. And so I think that's a really, really important finding in the last 12 months is that now as dermatologists, we have to have in our mind the concept of shedding or telogen effluvium. But I think we also have to have in mind the possibility that it pushes along genetic hair loss. And that's a big deal because I think that changes the conversation.
I think some people just probably spit out their water, their coffee or wine or whatever they were drinking when you just said that, because I think, again, where people are looking at these medications, and I think it's the way we sort of portrayed them, in the medical community, I think also online, that they are sort of the new, if you will, saving grace of just their impact, yes, on weight. We can have weight loss with them, weight reduction, improvement in diabetes, cardiovascular disease, and then, of course, they're being studied for a myriad of other things too, and the potential benefits. I think a lot of people, the hair loss piece, even if it is, 15%, that can make people hesitate. And if we could show some variations maybe in the type of GLP-1 or your likelihood, I think that could actually balance that argument. But I think for people that are genetically susceptible, that'd be very interesting. Like, how do you pinpoint who those people are? Because that is one of the greatest fears, I think, of a lot of people, just the significance of hair, the cultural and social and emotional impact our hair has for us, to think like, great, I'm going to get healthy in other ways, but would I be willing to do it at the expense of losing my hair? And I know there's a lot of my patients that would probably say, no, I don't think so. But like you mentioned, there might be ways we could sort of balance that or combat that. I was going to have you just dive a little deeper, kind of explaining the telogen effluvium a little bit more, because I do feel like patients are like, what does that really mean? Just to have shedding. And with GLP-1s in general, if that happens, does it tend to get better over time, or does some people have it more of a chronic fashion if they're on the medication long term, which is ultimately the goal, I know, for a lot of patients?
Yeah. So a telogen effluvium is a process where the hair sheds whenever it feels that there's been some kind of stress. And so we know telogen effluvium happens from when you have low iron or thyroid disease, or you start some medications. And so sometimes the body interprets the weight loss that is occurring as being a stress. And so often patients will get shedding, if they are so susceptible, about 2 months after starting these GLP-1s. Now, most people will continue to shed if they're a shedder until the weight stabilizes. But then once the weight stabilizes, the vast majority of patients will return to normal shedding patterns and normal density again. And I think as dermatologists, that's the tightly knit story we want to have, that you shed, and then when your weight is stable, you stop shedding. The reality is that some patients follow that story, but not everyone does. And so some people will continue to shed. It's a small proportion. And then some people will say, hey, it's been 7 months of being stable on this weight, and I didn't get my hair back yet. When is it coming back? Those are the people that are probably having their androgenetic hair loss
Gotcha.
arriving on scene or being pushed along.
Mhm.
But the vast majority of patients will stop shedding, and a lot of them will get their hair back. It's just we don't know what to do with the people that don't fall in that category yet.
And I think that's the scary part for those folks because, it is unpredictable, right? Who's going to be in that category. So I'm kind of excited as we learn a little bit more and studying kind of, where this happens. So, I think too, if somebody does come in to your clinic and they were put on a GLP-1 for whatever reason, because now I even understand we're looking at these for other forms of hair loss that they might even be beneficial, which is something I'll probably have you touch on because I think that's also the opposite of probably what a lot of people are thinking out there, since the focus has been so much on them causing hair loss, obviously. But if, for people that, come in and they're experiencing it beyond, I know we talked about maybe checking some lab work, are there other recommendations that you have that you can approach, to treat it while they're going through that shed phase, if you will, or maybe even if you think they're approaching androgenetic or female or male pattern loss as well?
Yeah. And I think that, certainly if patients are having evidence of uh, evolution to androgenetic hair loss, whereby one part of the scalp is thinning much more than another. Perhaps the back of the scalp is thick, but it's the top that's really dramatically changing. If there's hairs that are getting thinner, and we call that miniaturization, if there's miniaturization that's occurring, then it's possible that you do have androgenetic alopecia that's part of the scene now. And androgenetic alopecia is not reversible to the same way that hair shedding is. And so it requires a little more attention. We can wait for shedding to stop. We can wait for it to grow back. But if there's androgenetic hair loss on the scene, then starting something like minoxidil, if appropriate, or anti-androgens or laser or PRP or other treatments could be appropriate. But the reason those are such big deals is because those are lifelong. And so it's really important to see a dermatologist to get an accurate diagnosis. Hey, is my hair loss just telogen effluvium, or is my hair loss telogen effluvium and androgenetic alopecia? The treatments are slightly different. And so I think proper assessments are really important.
And I would agree with you because, as I mentioned earlier in the podcast, and I don't know as much, and maybe in Canada, if you feel like this is as common, but definitely I feel like here in the States, when I have patients come in, they're like, oh, I didn't even know you treated hair loss. Like they're surprised as a dermatologist that this is something we specialize in. And some people may have gone just to talk with somebody at their salon, or they have a trichologist or somebody else that they've chosen to see or talk with, maybe their family doctor first, which makes sense to start there potentially. But it's amazing how many people delay coming in to get an accurate diagnosis as well. Do you feel like that's similar where you're at, or are people pretty astute in coming in to see derm for hair loss?
I think delays are common. I think that intuitively, we've been seeing this stuff on the top of our heads for however long we've been living, and we feel we must know about this. We must understand this. And, a couple of keystrokes into Google or Reddit, and you feel like, okay, I got the gist of it. And so you feel that, what's this person going to tell me any differently? They're just going to sell me something. I don't want to go. And so I think people are really surprised that, there's a whole science behind hair that's increasingly researched and increasingly studied. And I think that's really exciting because, there's a body of literature that guides us in some of these decisions. And, to follow up on one of the points you made earlier, what recommendations do we have to patients going through a shed? I think the first thing I say to patients is it's okay to be upset. It's okay to have every emotion in the books. It's okay to be upset and angry and happy and sad and joyous, and whatever it comes is okay. And the second thing that's okay from my perspective is to do with your hair what feels right. I think if you want to wash your hair every day, fantastic, go for it. If it really bothers you and you find when I do this, it just is really emotional, then don't. But you're not making your hair worse by shampooing every day. The hair that's going to come out is the hair that's going to come out. And so if you want to take it out slowly day by day, shower or shampoo every day. If you want to do a once a week thing where you just deal with the emotional impact once a week, then do it once a week and you're going to have a lot of hair coming out that day. But it's your hair. So wash it how you want, style it how you want. A lot of people will say, you know what, I was told don't color it, don't cut it, don't heat it, don't. And my feeling is, what's happened has happened. Your hair already got the message what to do a month ago or 2 months ago. It's your hair. What feels right, do it. If you color it, you're going to have colored hair that's shed. If you heat it, you're going to have heated hair that's broken and shed. But, I think what's important is really for patients to have that little ounce of control. If I want to cut it, I'm cutting it. If I want to color it, I'm coloring it. You're not doing any harm by doing this.
Love that because, the emotional toll and the anxiety that hair loss creates, and then the vicious cycle of how that impacts, hair loss going forward. I full-heartedly believe everything you just said because it gives patients a little bit of that sense of balance, or, in fact, I think it could help them dealing with their hair loss if they can still color their hair and they're not, terrified by the gray coming in addition to the thinning. At least we can give them something, which I think can help the emotional burden of it and maybe even potentially help them cope with it. And I always tell them if you can keep those anxiety and stress levels down, not only does it help obviously potentially hair to regrow and normalize cortisol levels and kind of help the body and the immune system and inflammation, but it can help, other health aspects too. So I full-heartedly agree with what you say. And I think that is a bit of a myth. I love that you kind of did that myth busting that people are afraid to wash their hair. They're afraid of certain things because they do think they're making it worse. And you're right. The hairs that's going to fall out, it's going to fall out. It's just, are you helping it along or letting it kind of do it, sort of on its own in that way? But yeah, you got to give patients that sense of control. It can help them, I think, through this journey of dealing with hair loss.
Yeah.
And you mentioned the minoxidil too, obviously for the androgenetic. Do you ever recommend it if you think they're more of a chronic shed type, phase two, if they're on a GLP-1? Do you feel there's benefit there if they are more in the chronic, or do you feel like if they're truly chronic, they're more than androgenetic picture?
So I think these are really important questions because I think the thing that people often forget is that many of these GLP-1 agonists are really required lifelong to maintain your weight. And so they're not treatments that you can go on for 6 months, get down to the weight you want, and then stop. Because we know from studies that generally the patient rebounds to the weight they were at. And so if a patient is shedding and shedding and shedding, and they've been on a stable weight and they're still shedding, absolutely my very first thought is, I wonder if this patient is developing some androgenetic hair loss. Maybe they're not truly a chronic telogen effluvium. Maybe they're developing some genetic hair loss. And so I'll examine the scalp carefully. I'll look for the miniaturization. And if
Mm-hmm.
there's any uncertainty, I might even consider a biopsy because that really changes the treatment plan from being, we have time to wait, we can maybe, just see what happens, to, maybe getting on a solid treatment plan is the way to go.
Mm-hmm.
But the reason I'm always hesitant about minoxidil, unless I'm sure, is that for androgenetic alopecia, minoxidil is lifelong. And sometimes what happens with chronic shedding is you start the minoxidil with the feeling, let's see if it stops your shedding. And if we want to stop, we can stop anytime, because for shedding, the rules are you don't have to use it lifelong. You just use it however long you want. But sometimes in those people that you put minoxidil on, if they are evolving to androgenetic alopecia, what happens when you stop the minoxidil is their scalp says, why did you stop the minoxidil? Didn't you know I have androgenetic alopecia? And so what happens is you get a reduction in shedding in that patient. And then when you stop the minoxidil, the shedding goes back up. And the patient says, wait, what's happening? Well,
Right.
what's happening is you've declared that the patient in front of you has androgenetic hair loss. So they're tricky conversations, and I think they really require that kind of dialogue with the practitioner.
Yeah, really important. I always, I tell my patients, those those hair follicles that like the minoxidil, it's kind of like they're fixed. They're a little addicted to it. And if they're the ones that need it, you pull that away. I mean, they just kind of, those are the ones that are come out. But I like it is, kind of a conversation with the patient. Do we do a biopsy? Do we investigate further? If we do attempt this minoxidil, if we stop, we expect, potentially if you're the androgen, it's going to revert back, to your old pattern where, those hair follicles that needed it, if they're not getting that fix, they're definitely going to show you that for sure clinically. And that is a hard conversation because it is hard to wait. I think too, when somebody is telogen effluvium for patients, it's hard where they feel like they might be limited in treatment options, but there are a lot of other, things out there that are buzzy about treatment options too. So I was going to have you touch a little bit upon, because I get patients that definitely, there's still this concept that natural is always better, right? And, in our area, people come in, they're like, well, what about rosemary oil? What about pumpkin seed supplements? I read there was a study here that showed, that doing the rosemary oil could be beneficial. And so I was curious to see how you kind of approach that, and if you ever recommend that for patients that have hair loss associated with GLP-1s.
Yeah, certainly they are interesting topics that really we don't know enough about to recommend them, wholeheartedly. But we don't have any good data on how to treat hair loss associated with GLP-1s. We figure that if it is androgenetic hair loss, that you just follow the same rules and protocols that you'd use for androgenetic hair loss. And when it comes to rosemary for androgenetic hair loss, the thing I always tell my patients is, I know you mentioned that study. I'm so glad you did. But did you know that was twice a day, that oil? So it wasn't just a drop of rosemary in your shampoo that you use once a week. It wasn't just rosemary that you pick up when you remember it once a month or once every 2 months. It was twice a day. And, rosemary can cause itching. All the essential oils can cause itching. They can sometimes be greasy. They can sometimes be challenging. And so, they are options for patients that say, I don't want minoxidil, I don't want laser, I don't want anti-androgens, I don't want anything but something that came naturally. I'm okay with it. I fully support my patient that way. And for the pumpkin seed oil, I think that it's on the list. It's certainly not on the list as a first line or second line option. I think these are really third line options. And so I say to my patients, I kind of imagine it like a toolbox. When you open the toolbox, you've got the first line agents at the top. You've got the minoxidil at the top. If you want to find the rosemary and the pumpkin seed oil, you got to dig deep down. And it's just a reminder that we really don't fully understand how well those work in the big picture. If you use pumpkin seed oil for 6 months, maybe you get a benefit based on the studies. But if you use pumpkin seed oil for 24 years, are you still benefiting at year 24? We don't know. And so there's a lot of unknowns. And I think what I'm excited about for the next few years is, as we understand more about GLP related hair loss, how do we treat it? And what stories are out there? And I think that's so important for your clinician listeners, is not to get too wrapped up in GLPs cause telogen effluvium. Once the weight stabilizes, hair grows back. We know now that that's not correct. And so be open to listening, be open to observing. And if you're finding these different patterns, consider sharing it. I have patients, for example, that say, do you know, I'm absolutely certain that I develop hair loss a week after my GLP-1 started. And you'll say to them, that doesn't follow the rules. It's supposed to be 2 months. No, I'm absolutely confident it was 1 week. And I think there's a lot of these stories out there of patients that have all different patterns. And I think as a dermatology community, we now have to share these stories to understand it better, including how to treat it.
And I was curious too, just to kind of wrap up in the last few minutes we have, what about, some of these regenerative techniques, that people talk about, like PRP or exosomes? Do you feel like they have any role, or do you really feel like it's really, if we're seeing that GLP-1 associated hair loss that we have know of now, that's more androgenetic in nature, or is that something that you've attempted in patients that are more of a chronic shed?
Yeah, most of our patients with chronic shedding and evolution to androgenetic alopecia we're starting minoxidil topical or oral, and in some cases anti-androgens as our more standard protocol with androgenetic hair loss, sometimes laser. We don't know enough about how PRP and exosomes fit in here yet. I certainly view those as second line. And so I really feel kind of a sense of following protocol when these patients are having hair loss, because I want to try to put the best odds on in their favor. And so I feel right now that maybe, just maybe, some of those treatments like minoxidil might have better odds for them than other treatments, but they're certainly on the list. And I think if someone says, I don't want minoxidil, I don't want anti-androgens, I did laser, it did nothing, then we have things like PRP on the list. And I think it's very reasonable to pursue that. The thing that everybody with androgenetic hair loss needs to remember is that's PRP lifelong.
Mm-hmm. Yeah, I think the chronicity thing is the scary part, because we're used to sometimes with certain medications, they can cause a potential shed and that can stabilize, right, with certain medications. If this is going to be a longer process or potentially that evolution, as you mentioned, into androgenetic alopecia, it is hard. We don't know who those people are going to be, but I think you really summarized it well, where you're like, hey, be open to it, monitor these patients, explain to patients, around 15%, actually will experience hair loss when on these medications. And although we don't know how to prevent it yet, we can definitely be vigilant because, I think the data is definitely sound in showing the benefit it can have for some of our patients. And I hope they're not deterred by the possibility of potentially having hair loss. Jeff, any other final comments or things that you would share about GLP-1s and hair loss as well for our listeners?
I think you said it, that, these drugs are really revolutionary for so many things, and they're helping with weight loss. They're helping with insulin resistance. They're affecting people's, cardiovascular risk, and they're improving quality of life. And so there's so many good things about these medications. And so it's just these delicate conversations about risks and benefits and thinking about these and, teaming up with your practitioner and saying, hey, this is what's happening. What do we do? And, knowing that there's options out there and having those careful discussions. But, the final message is stay tuned. We're going to be learning a whole lot, and our conversation next year is going to be different than this year. So stay tuned.
We'll have to have you back on to give us the updates, because I know there's a lot of people just waiting to find out where this is headed, and who knows what doors it may open, up for just hair loss in general, because obviously many different types, and we still have room for improvement in treating it in dermatology and helping patients out. So thanks so much for coming on the podcast, Jeff. It was great to have you here today.
Oh, thanks so much.
Of course. And stay tuned for the next episode of Derm-It Trotter. Don't swear about skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.